Welcome everyone. I just noticed
Welcome.
there's a little bit of a delay there to me starting. That's why I did the thing again. Anyway,
Uh-huh.
welcome everyone to the show today. Glad you're here to join us on Thursday Roundtable. Very excited about today's panel for a couple of different reasons. But without further ado, I do want to just go ahead and introduce them. I'll tell you the reasons why I'm very excited about our guests today. So first of all, in the middle of your screen, you have Kalon McMillon. He's the co-founder of Archaic Care. Welcome to the show.
Welcome. Thank you so much for having me on.
Awesome. And then I also have Miss Ammie Plowden. She is also a co-founder at Archaic Care. Welcome to the show.
Thank you so much. Thank you for having me.
Awesome. Well, a lot of the folks who I have on the show, most of them I don't know very well. Perhaps we never even met before, and we're on live one day. But it just so happens that I've known you guys for several years, and I'm very excited about what you guys are doing now in the space. You're in my space, which is the healthcare space, where I'm in your space, in the healthcare space. So glad to have both of you and appreciate what you're doing to help address some of the staffing shortages in healthcare. So thank you both.
Oh, thank you so much for having us on. Very excited to be collaborating in this way. And yes, we've known each other for a good amount of time.
Yes, sir. Yes, sir. I'm not even sure how many years it's been. I know for you, Kalon, it's been a while. It's been a minute.
2010.
Yeah, so you're talking 12 years.
Mm-hmm.
Yeah. And Ammie, I know I've been knowing you for several years now. However long you've been in Houston.
We moved to Houston in 2015. So
2015.
I've known
Okay.
2015. Mm-hmm.
7 years. Awesome. Well, guys who are just now coming in, let us know where you're signing in, what city, what state, what country. We're talking about how we can address some of the staffing shortages that we're seeing in clinical practice. And we're just finding ourselves in a situation where a lot of clinics just are not able to keep fully staffed. And so from your perspective, what are some of the reasons? I'll start with you, Kalon. What do you think are some of the reasons why these clinical practices are short-staffed today?
I think the most glaring one is COVID-19. You know, a lot of people got overworked during that time. I was reading one article that said 1/3 of doctors and nurses have planned to reduce their workload just because of the pandemic and the stress that it caused them. So I would say the pandemic, as well as there's always just a healthcare professional shortage. People are always sick, you know.
Mm-hmm.
Absolutely. How about you, Ammie? What are your thoughts on that?
I think Kalon made a really valid point about COVID-19. That was kind of the turning point. But, you have your usual stressors. The fact that it's a very demanding job. And when I say demanding, it's like demanding physically, mentally, emotionally. And it's very stressful at times. So I think that all of that contributes to the fact that the shortage.
Okay, very good. Appreciate that. Now, we talked about some of the causes. Now, how is that impacting some of the clinics and things that you've interacted with in your business? How is it affecting them from their end? What would you say that, Ammie? We'll let you start, and then we'll follow up with Kalon's thoughts.
I think the biggest impact is with the patients, because I don't think that the patients get the full attention that they deserve because of being understaffed, and that's unfortunate because that's what this is all about. It's all about patient care, and I think many times that they're left out of that paradigm, if you will. So that would be the biggest consequence, I think, of the staffing shortage. And because there's a staffing shortage, many times the nurses have to take on roles because there isn't another nurse there, and so it's overwhelming what the responsibilities they have to do because of the shortage. But my biggest thing that I'm sorry for is for the patients, because that's why we're there, and they can't do anything about it.
Yeah. Do you feel like some of these clinics, I know you're saying they're doing extra jobs. Do you feel like because of that, these RNs or doctors or whatever the case might be, do you feel like they're really able to work to the top of their license because they're actually having to do all these other things? What are your thoughts, Kalon? Oh, go ahead, Ammie. Go ahead.
No, go okay. I'm sorry. Go ahead.
I would say no. And it's a harsh reality of where we are in healthcare. I'll just give you an example. So I was in home health for a while, and I would be following up on patients that the doctors have assigned to us. And let's say a patient has a blood pressure that's really high, and I need to follow up. And so I call to the doctor's office. I can't get to the doctor. I'm on hold for 15 minutes and I'm there at the patient's home. And then finally I get somebody and they say, well, this nurse is not available, but can I take a message? And then I leave a message with someone who's only in charge of intake, who's not clinical. And then that message needs to get to the nurse. And then that message then needs to get to the doctor. And so I might get a call back 2 days later to say, oh, the patient's blood pressure was up 2 days ago. So meanwhile, the patient was in distress. So I think the biggest gap is not, it's the understaffing for sure, but it's leading to that lack of communication, lack of continuity of care from the patient's home to the clinic. So because the real problems and issues are happening not necessarily while the patient is in the clinic with you, it's when they're at home, and so that communication there is key.
Makes sense. Makes a lot of sense. And I would think that in some cases, in that case, it may not have been consequential, but in other cases it might be because they needed that contact within that 2-day period you mentioned.
Correct.
Absolutely.
So let me ask you this: what are some if clinics are finding themselves in a spot where there doesn't seem to be a clear answer in sight? So give me some other ideas or other solutions that you come across that seem to work well with some of the practices that you're interacting with. Let's start with you, Ammie.
I know one of the things that I saw that I thought was extremely helpful, but they actually eliminated the program. When I worked in Wisconsin, it was called the 770. So what that meant is that you work 7 days on, 10 hours per shift, and then you had the following week off. And it made a tremendous difference because they actually gave the nurses a chance to reset and to be able to go in and give the patients the care that they needed. I absolutely love that program. And I don't know why, but they eliminated the program. But it was a very popular program to the point that all the nurses that work within the hospital wanted to be a part of that program because it created a work-life balance. And I thought it was absolutely excellent. But I still to this day don't know why they eliminated that program. But I saw that being a huge benefit to not only the nurses, but the patients that we're caring for.
Wow, that's interesting. Yeah, I haven't even heard of that before. 7 days on, 10 hours a day. Guys in the comments, let me know if you've heard anything like that before. And what do you think? Do you agree with Ammie that seems like that would be a really good solution? And help us figure out, I wonder why they're not doing it. If it's something that was in demand, that's very interesting. Okay, Kalon, what's your input on this? What are you thinking in terms of what are some solutions you've seen that work? Including, I know you guys are doing things to help practices as well, so you can feel free and touch on that.
Okay, so what I've seen work the best is you have some kind of home care, home clinic being set up in the patient's home, right? That way you have some medical professional that is visiting the patient where they are. So they're seeing, you walk into a patient's home and you open the cabinets and there's 5,000 pill bottles. They haven't took any of their medication. The doctor doesn't even know. He just keeps prescribing, right? Or you get there and they're on 10 blood pressure medications, but they don't have a blood pressure cuff in their home. So what I've seen work the best is somebody visiting in the space or at least calling the patient at home. That way that they can see what's actually going on in the home. Because once you can kind of get things right in the home, then that's where the real patient outcomes take place. And a part of what we're doing is, a clinical outreach program. So we reach out to physicians' patient load that they have on service, and we get involved. We're asking the patient if there are any new medications, if they're having any side effects. What is their current blood pressure? We set them up on remote patient monitoring so we can keep an eye on what their blood pressures are. If it's a heart issue, we have pulse oxes and different things like that to monitor a person's vital signs from home. That way we can see what they're running at in general. Because you can get into a situation as well where it's, let's say a patient has the doctor's appointment, right? They get in the car. They're not used to doing a lot of stuff because usually the elderly patients aren't really used to doing a lot of stuff. So they get in the car, they sit in traffic. It's painful to get in and out of the car. It's painful to walk into the doctor's office. And then they're waiting in the doctor's office and it's taking longer than it's supposed to. Then they finally get to the doctor and they take the blood pressure and the blood pressure is sky high. And so the doctor's like, oh, your blood pressure medication is not working. We give you some more blood pressure medication, but it might have just been the day stimuli,
Yes.
So it's much better practice to monitor the patient at home every single day. They're taking their blood pressure the same way, the same time. And that gives the doctor a better picture of what the blood pressure actually is, what their pulse actually is, what their pain level actually is, as opposed to prescribing just based off that one clinical visit that's 20 or 30 minutes long. And so that's really what we're seeing the future of healthcare should be. Meeting the patient where they are at their home, clinical outreach programs, getting involved to make sure that these patient outcomes are happening at home. And that's why we're doing what we're doing with eye chronic care.
Love that. That's awesome. Okay, now I gotta Lillian is visiting us. Good to see you again, Lillian. Thanks for joining us. She has a question. Maybe one of you have heard about this. Are LVNs and RNs still requiring COVID pay? Is that still going on right now?
That's a good question. I'm really not sure what the answer is for that, but I believe so, but I'm not definite on that.
Okay.
So I was a COVID nurse for hospice and home health. And at the last time with Omicron, I believe that we were still getting, I know that we were still getting COVID pay. And so I think it's still going on at certain locations, but it may just depend on the administration that you're working for. But I know at least up until Omicron, for sure, LVNs and RNs were able to, say, hey, it's COVID, I need COVID pay. And they were still getting that. So, but that's a great question. Great question. My answer would be follow up with the administration wherever you are to try to verify that. Don't let them just leave it as an open-ended question. Just follow up, and more than likely you might get a positive answer.
Very good. Appreciate it. Lillian says thank you. Okay, so the other thought I had is you're talking about how it's important for these practices to have this kind of home interaction. And it makes sense because I actually was in a similar situation years ago when my pressure was a little up when I visited the doctor. And they're like, look, you got to get this thing straight, or you got to go to the doctor. Go to the hospital. And of course, they got me really excited because I've never had any issues with blood pressure. And so I went and bought me one of those little blood pressure machines. I was looking up how to check my blood pressure, and I would check it, and it would be high, right? It would still be a little bit high. So I would work on little things and they would get low. But I was noticing that it had to do sometimes with like me checking each arm sometimes, or how high my arms were elevated, but it would get me scared because I wasn't doing it right. And so it was off. So I could only imagine if we're talking about elderly patients, there's a number of things that can get them worked up, like you said, traffic and everything, or if they're not doing it right. But if they had the actual person helping them at home, that'd be awesome. But the biggest thing I'm thinking about is they're already short staffed. How are they going to have enough staff for that? So, like, where do you guys come in?
Okay, sure. So where we come in is Medicare is seeing the same things that we've seen, right? They're knowing that in between these patients' PCP visits, they're ending up in the hospital due to an exacerbation with their CHF, their HTN, whatever it is. They're ending up in the hospital. So Medicare is putting more money into preventative as opposed to reactive healthcare right now. So they are actually able, we are actually able to bill Medicare in order to check on the patients in between visits with their PCP. And this is on a 20-minute increment scale. We call the patient, we go over the care plan. We have our RN case manager who does all our care plans. We have LVNs, we have medical assistants, all of which are a part of the clinical team. And when we call the patient, we represent ourselves like we are from the doctor's office because we are, again, a clinical outreach or an extension from the patient. And the great thing about it is, the awesome thing about it is, as Ammie was speaking to earlier, a lot of good nurses were already doing this, but they just wasn't getting paid for it. Right, Ammie?
I worked as that's a really good point, Kalon. I worked as a nurse in the field And what Medicare now recognizes as that they're able to quantify what we were doing and be able to give some type of reimbursement for it. I did that for years, and you never got any accolades for it because to me, it was just good nursing practice. It's what you should do. But now Medicare, I believe on the CMS website, has 3 different studies that have been conducted to show conclusively that this is beneficial for the patient. And it absolutely is, because I took really good care of my patients because there were a lot of things that you did to help them navigate through the health system that they really appreciated. You didn't get that type of appreciation from anyone else in terms of your salary, but your patients really appreciate it. When I relocated here to Texas, I left, like I said, in 2015 to Texas. My patients were still calling me. They absolutely loved the care that I had. I actually had to change my phone number in order to stop calling me because I went over and beyond to help the patients and do things sometimes you didn't have to do as a nurse, but you did it because you know that it benefits the patient. So it's really refreshing to see now that Medicare is recognizing the benefit of this and improving patient outcomes. Because like I said, what it's about is the patient ultimately. You know, we talk about doctors, nurses, LVNs, MAs, whatever, but it's about the patient. And so I'm glad to see some things are being done that benefit the patient.
You know, you guys, I always have my recruiting hat on. And so as I have my recruiting hat on, what I'm thinking about is there's a lot of nurses who would like to have this type of setup where they could work from home, probably with an organization like yours, because they may be in a situation where they either can't go in the hospital because perhaps they have older folks in the home that are maybe could be more immunocompromised. Maybe they're just a little burnt out from working at the bedside. And so this seems like another option, or maybe some of them are getting towards retirement, and instead of just quitting nursing, this seems like another way for them to actually keep engaged in the practice. So I'm just curious about that. Do you see this type of model that you guys have expanding where other nurses can work with you? Is that something you guys do?
Absolutely. When we think about the different struggles that nurses have to deal with in the field or at the bedside, it's not a surprise that many of them end up with injuries, back issues, pain, lifting and maneuvering patients for 30, 40 years, or combative patients at that sometimes. And so many of them still have the clinical skills and the clinical knowledge, but they can't necessarily go to the patient's home anymore or go to the hospital and do the bedside care. So I agree. It would be a great avenue for any nurses, MAs who would be interested in working from home. And the way I'm looking at it, and I'm sure Ammie feels the same way, this is the future of healthcare, making sure that patients are being taken care of at home. And I feel like many nurses will be interested, and we'd definitely be interested to have conversations with them if they wanted to join our team or if they just wanted to learn about the programs, period. And I did want to mention them by name. The CCM, Chronic Care Management, that's a program. RPM, Remote Patient Monitoring. PCM, there's Principal Care Management.
Okay.
Right. So those are the names of the programs that Medicare is sponsoring, and that's how we again become part of that clinical outreach program. But yes, absolutely. As far as nurses who are looking to work remotely, absolutely.
Yeah, I got RPM. I got RPM in my vehicle. It's right there on my dashboard.
If you look it up on Google, that's what will pop up. That's what will pop up. But one day when you look up RPM, it will be this program that pops up. I promise you, one day.
You see one of us waving like, oh, hello, hi.
So that's remote patient monitoring? Is that what that is?
Yep.
Yes.
Okay.
Yep.
It's
remote
not
patient monitoring.
It's not what's the other, revolutions per minute or something like that?
Yes. No.
Okay, I got a fun question for you guys.
Okay.
You ready? What was your favorite? I asked this last night on one of my live shows on Instagram. What was your favorite cereal when you were young? And guys, in the comments, tell me if you're watching the replay or live. I want to know what your favorite cereal was when you were young. I'm curious.
Oh man, that's so tough. That is so tough.
I'll answer that first. My
Okay, go ahead.
favorite cereal, there were a few of them, but the one that was my ultimate favorite was Frosted Flakes. I
Frosted
absolutely
Flakes.
love Frosted Flakes. That was one of my favorites, and it actually got me in trouble because I got some cavities as a result of eating too many Frosted Flakes. But that was my favorite. So
Yeah, this
What about
is
you,
a
Kalon?
tough one. That's a tough one. Man, Cinnamon
Well, wait.
Toast Crunch. If I have to pick one,
Ooh,
Cinnamon
that's
Toast.
that's a good one. That's a good one
Because
right
the
there.
milk after you eat it, I mean the milk is still good. It's got that good flavor. You can put Cinnamon Toast Crunch on anything and make it good.
Mhm.
That's a good point.
Yeah.
I'm liking that one. I said I was gonna go with Fruity Loops. That's what I said last night.
Yeah.
Fruit Loops.
Mhm.
Because the reason why
That's a strong
is
one too.
yeah, it's a strong right. When I was growing up, I couldn't drink milk. I had like this lactose intolerance or whatever. It would like create too much issues. Anyway, I created a distaste for milk, by the way, even to this day. But that was one of the few cereals I could literally just pull out of the box and pour it and just eat some like straight, and it would taste pretty good. So,
Honey Nut
So,
Cheerios, we can go on and on. So
yeah, we really could. You know, I really like the Frosted Cheerios because those would make anything that make the milk taste good afterwards. I was good with, but the Cinnamon Toast Crunch was the best.
see now you're getting into combinations because it's, with so many foods, it's like when you combine this with that, it really makes it that much better.
Mhm.
Yeah. Speaking of combinations, I'm curious, what was it that helped you guys to say, we should do this thing together? Like what is it that works between the dynamics that you guys have in business as co-founders?
Amy, I'll let you take that one because at first Amy didn't want to work with me, so I'll let.
Oh wow!
What? No,
Wow.
Tell the truth. Tell the truth.
The truth will set you free.
that's not true. I actually, I haven't been doing physical nursing where you actually go out to the homes, but I still had a lot to offer in terms of my clinical experience because over 20 years of working. And I was just looking for an opportunity to be able to bring this, to marry the skills that I currently have without using the physical self to be able to complete the task. And this just seemed like a natural fit. And I believe I was first introduced to this concept in 2018, but there really wasn't a formal process to be able to put it together. So over the years, I had collected samples and different templates that I thought that would help me to eventually to be able to do this business. And then I came across something in 2022 and I thought, wow, this is great. And knowing Kalon as a nurse, I thought, this would be a perfect fit. And we could still be in the nursing profession, but recognizing that we can't continue to go up and down a flight of stairs, indefinitely. So using technology was an excellent platform to still be able to use the skill set that I have.
I love that. Okay, Kalon, before you answer, I have to recognize a couple of people who come in since then. Farah says, hi, everyone. Hi, back to you, Farah. Thank you for joining us. She is also she's a nurse, and she's actually working towards her DNP, and she's a nurse educator up in New York. She helps new grads get their first job and helps them kind of coach them up so they'll be ready for their first job. And then Jody, I love Jody. She's on too.
Hey, Jody.
She's waving hello, and she says I think her favorite cereal is Sugar, which I never heard of it. I
never heard of that.
Wow. I thought she was just referring to me, but apparently that's some cereal. Okay.
Wow. Okay. Good job.
Nice.
Anyway, okay. Well, thanks everybody for joining us, and we're talking about ways that we can meet the demands of the patient demands, if you will, of the clinics because they're having a tough time keeping staff, and in some cases, I can tell you as a recruiter, they have a tough time competing with the hospitals because the hospitals have more revenue to work with, and so therefore they can pay sometimes the nurses a little bit more. So that's another factor. But I think that we're on to something here. So I say we, I mean, you guys are on to something here because there's a lot of nurses who they are not, their life or whatever their goals are just don't really fit with bedside right now. And so this gives them another alternative to stay in nursing, keep their clinical skills, relevant, like what you mentioned, Amy, but they can actually do it from home And then, of course, you need to go visit the patients as well. But you talked about remote patient monitoring. That's one where you probably could do it remotely. Assuming by name. And then there's probably another set of folks who would need to go visit, or is it usually the same nurse? Is it a different nurse or is it the same nurse? So now I'm asking you recruiting questions now.
No, it's all good. It's all good. I love it. So actually with the software that we have, everything can be done remotely.
What?
Everything can be done remotely. With the software that we have, everything can be done remotely.
Wow. Right? That's amazing.
So the doctor, let's just walk you through a typical patient. So the doctor wants to institute a chronic care management patient program for his patient. The patient comes in for their regular visit. The doctor tells them, hey, I have this program I would like to get you into. There's going to be some nurses from my office that will be reaching out to you to connect with you at least once a month or every other week, depending on what your healthcare needs are. And here's what you need to sign up. They go over it right there in the office, and then they'll be calling you. So from there, or if it's a remote patient monitoring, we can get the device delivered to the home. We can walk them through it via video conference so that they can see us, how to use the equipment to make sure they're using it properly. And we can talk them through it as well over the phone. So everything can be done remotely.
Wow.
And we're trying to make the process as simplistic as possible. With the different devices that we send in the home, the patient shouldn't have to do anything really, but just hit one button, maybe two at most. And so most patients can do that, and we'll still be able to get the data that we need to then to be able to submit it to the doctor's office. So
yes, because we know there's some technology challenged people out there, and some of the older patients may not be as eager to use technology, especially if they've had problems in the past with it. But I think anybody can click two buttons.
Yes,
it should be.
Yeah. But you know what's interesting? We are actually coming up on in the next 5 years. People who are over the age of 65 will have spent time using an iPhone or some kind of device.
That's true.
In the next 5 years. So again, the clinic is coming home because we got the technology to do it now.
That's true. It's a good point. And also I'll say this, that, it used to be, Facebook, for instance, was just for the young folks. Well, now it's considered to be for the old folks.
Yes.
So you got a lot of people who are older.
Who you calling old?
Look, I'm just telling you, when you talk to teenagers, they say, like, the Facebook, that's for old folks. We don't use that. And then you have those who, and they use Instagram, right? And then you have some who use Instagram and they don't want to use that anymore. They're like, no, we're on TikTok. We only use TikTok or Snapchat, Yeah. And so that's interesting, what you mentioned. Thank you for opening my eyes to that, Kalon, because as things progress, your older patients do have these apps. So they're used to using apps on their phone. So why not just add one more that's going to help keep healthy, keep them out the hospital, which, by the way, they don't want to go to the hospital. They don't want to go to the doctor's office.
True.
So that's more motivation to learn this app, whatever it is.
Absolutely.
Okay. So we're at the halfway point of the show. This is that time when usually we take a little bit of a water or a beverage break, whatever you want to call it. I just so happen to have this. I usually have water though. I got some water here too, though.
Brown
I got some
water?
Yeah, it's brown water, but I got some water here too. Here we go.
So Tamara has me. That's my wife, by the way. Tamara has me on a water challenge where I gotta drink this thing. Right?
Okay. Well, Jody would be happy to hear that. She's probably gonna put me on a water challenge here in a minit. Hopefully,
I'll send you a jug.
Maybe Jody's. Hopefully Jody didn't hear that. No, I'm just kidding. No, I'll drink the water. Okay, I got a question for you guys. You guys, as well as those who are watching on either live or on the replay. Okay, this is a would you rather question. Would you rather do a mini cheer whenever someone compliments you? That's one choice. Or always have to wear a kick me sign on your back. Which one would you take?
I'm taking the cheer.
Yeah, the cheer.
I don't want nobody kicking me. I'll just be embarrassed, but I won't be hurt.
Well, if you're looking tough enough, you're looking tough. Maybe they might not kick you.
No.
Away from the kick.
And look, and Amy will make sure she'll have Lenny next to him and make sure nobody messes with her either.
Oh yes,
there you go.
She can have the kick me sign.
So, but both of you guys say you want to do the mini cheer. Okay. Now, did you guys want to practice a cheer right now?
No.
What? Show us what you got, and then we'll see if we can
we'll follow.
Okay, in the comments, let us know which one you'd rather choose. If you had to choose between giving a little mini cheer every time someone compliments you, or you would always have to wear a kick me sign on your back. That's no compliments or not. It's just all the time.
Wow.
Yeah, so I think I'll do the mini cheer. I cheer anyway sometimes. Not like rah, but I'm like, yay, So anyway, all right, going back to our discussion. Now, what do you, if you had, being as you've been involved with home care, you've done the remote patient monitoring, you've done the chronic care management, I know you've had different practice settings. Just overall, what would you say would it be the top 2 or 3 tips that you would give to a clinical practice to help them to be better in terms of operating more efficiently with a shorter staff?
That's a good one.
I would say they definitely need to utilize programs that we're offering through iChronic Care or a similar platform, because they do need some help. The clinics are really taxed already with the different responsibilities that they have to do with caring for the patients when they come in the clinic. And so to have that leverage of having someone out in the field that can then help to be able to navigate their healthcare system, it's a win-win. Why wouldn't you do it? So, and the clinic wouldn't have the responsibility of doing it. The staff that you would hire would have that responsibility. But we can be the advocate for the patient to then be able to help them improve outcomes. And that's what it's all about. But it's about improving patient outcomes.
Well, okay, I'll give you an answer back, and you can answer this question. So if I own a medical practice, and I'm saying, well, you're like, what do I have to lose? Why would I do it? Well, there's got to be a cost involved, right? So, how does that typically match up? I don't need to talk exact numbers, but how does it typically match up with the reimbursements or however that works on the payer side versus whatever the cost is associated with having your service?
So Medicare gives a reimbursement based on each 20 minutes of interaction if you're doing CCM or RPM. And then if you're doing RPM, Medicare also reimburses for the monitoring itself. So a company like ours would provide the services, and then we would charge the clinical practice a portion of the money that they would be reimbursed by Medicare. So they would be essentially being able to add new medical staff to their practice without taking any additional costs, and be able to actually generate more revenue for their practice as well. And we've had many stories of, because we like the private, we'll work with whoever, but we do like the private medical practitioners and their practices. They'll say, I was thinking about shutting down my practice. This is going to save my practice. It's created more revenue. I can actually have more staff and be able to provide better care to my patients. This is exactly what I was missing, or what I was looking for, what I needed for my practice to continue to grow and succeed.
Love that. And so
most patients already have, they're on Medicare. They're also on Medicaid. So they're already dual eligible clients. And so the coverage for the services will be covered by both of those insurances. And also 85% of people that are on the Medicare population have a supplement. And so Medicare would cover 80% of those costs, and then the supplement would pick up the other 20. So most of the time there is no cost to patients, and that's very important to us, because we know that somebody's on a fixed income, just a couple of dollars can make a difference. So with most people having that type of coverage, it can be covered at no cost, additional cost to them. So. That's
really cool. Yeah, it sounds like a no-brainer to me. That's awesome. Okay,
we're hoping everybody else feels that way.
Yeah, well, and just like any other business, getting the word out and educating the customer that this exists, number one, and that it's something that could work for them, number two. It's not an easy task. So it's good that you're doing things like this with outreach to let other folks know more about what you're doing. Okay, so essentially what I'm hearing is that if they take this on, because you're only charging a portion of the reimbursements that are coming in, and you're absorbing all the costs, I guess, of the program. I'm guessing. So it only is an ad. There's no cost that would take from the bottom line of the practice. It only adds. Is that correct?
Correct.
That's 100%
Am I missing something?
correct.
Okay.
That's 100% correct.
Wow, that is powerful. That's very powerful. Okay.
Well, again, Medicare has basically put their money where their mouth is, right? And you know, they've seen how important it is for patients to be cared for in between PCP visits. I think it was $30 billion that they put into it last year. And so, yeah, I mean, but that's just a fraction of what you're paying if you actually end up in the hospital. If all these patients actually end up in the hospital, it could be $10,000, $15,000, $20,000 just for a day in the hospital, as opposed to paying a clinical program like ours, you know, $56 a month to do a couple of calls and manage their chronic care conditions.
And it's been my experience that patients actually love the programs, because sometimes we're the only communication that they have. You know, sometimes they don't have families, or they don't have, you know, depending on their situation. And for them to have a personalized nurse that's assigned to them that can call them and not only talk about their health care, but just talk about some other things that are important to the client is really important to the client. And they really do appreciate that relationship. And it's a joy that I've found that in my practice, when I've done CCM, they absolutely love talking to us, because it's like, oh, goody, here's my visiting nurse that's calling me to see how I'm doing. I absolutely love it. So it's really a win-win situation.
Yeah, I mean, from the client standpoint, it's like they have a concierge, you know, nurse, you know, that calls them whenever they need them, you know. That's really cool. Okay, so in terms of, I'm curious, and because Pharaoh, I see Pharaoh is watching. I'm curious, is this something that you can take someone who's newly out of, or do they have to go in a hospital first for a while, or is this something you can work with new grad nurses on? Is this even a path for new grad nurses? I'm just asking in general.
For nurse practitioners, yes. So if you were a nurse practitioner, and let's say you're a family practicing nurse practitioner, and you build up a clientele, or you're working with a physician who has a clientele, Medicare does allow nurse practitioners to write orders for this service as well, be it RPM, CCM, whatever the demographic is for the patient. We can help them as well. So if they're a new nurse practitioner, if they have the patients and they have the clientele, or they do it with a doctor, supervising physician, we can work with them as well.
Got it. So, but to work within your program, because I know you guys are going to be bringing on nurses eventually, to work within your program, what I'm getting from your answers, they need to be experienced before you guys would work with someone on your team doing this type of RPM. Is that correct, or am I getting something wrong on that?
The more experience, the better. Can I put it that way? The more experience, the better. Because there's one thing to be in person dealing with the patient, but if you have a patient over the phone, you gotta kind of know what it looks like if you're not there. You know what I'm saying?
Okay, yeah.
So it would definitely be better if they have experience, and you know, they're easy to get experience. Not a you don't need 5 years experience, but
okay.
You know what I'm saying? Somewhere we're in the realm of, you know, having some background in healthcare, knowing what the patients are going through, knowing what the current healthcare model is and where the gaps are and how we fill them.
So maybe after a year or two, possibly? Is that a possibility?
Absolutely.
Yeah,
absolutely.
I would say you definitely having that experience, especially for the CCM program, because a lot of times, because you're not face-to-face, as Caleb brought out, you have to be able to assess what's going on with the patient based on your experience. You know, you can tell by different symptoms that they're having what's going on with the client, and then you can intervene on their behalf. So having that experience would definitely be beneficial. Doesn't have to be a lifetime of experience, but having that experience, because you got to be able to read between the lines sometimes, and that experience will give you that ability to be able to determine what that is.
Okay, that makes sense. Okay, all right. So I got another fun question for you. Are you ready?
Ready.
So All right. So do you want, I'm going to go with you first, Ammie, on this one. Do you want open-ended or do you want would you rather?
Do I want to open-ended or what?
Either open-ended question or would you rather?
Open-ended.
Okay, open-ended. Okay. What archaic form of technology do you cling to? Like what's that? What's just that it's an archaic form of technology. You just can't move, you just can't get rid of this. You have to keep it. What is that?
Miss Pac-Man.
I wasn't gonna guess that. Wow, Miss Pac-Man. You still play Miss Pac-Man? Wow.
Oh yeah, I love Miss Pac-Man. Yeah.
Wow.
Interesting. See, I never
No
know what
matter
I'm
all
gonna
the
get.
new games that come out, just keep going back to Miss Pac-Man. I don't play many video games, but that's my favorite. Miss Pac-Man.
Wow. Okay, and guys in the comments, I want you to answer the same thing, whether you're watching live or on the replay. Okay, Kalon, what's your go-to or your archaic form of technology? You cling to it. You just.
Oh man, that's so tough for me, man. I'm a millennial. When it comes out, I want the new stuff, man. As soon as it comes out, I'm ready to get rid of the old and go to the new stuff. If I had to pick, so, I mean, I held on to my generation 1 iPad forever. I don't know, is that archaic enough?
That's pretty archaic. I think it came out in 2010.
Millennial, yes.
Yeah, that's 12 years. That's a long time, man. So yeah, that's pretty archaic. For me, what's an archaic? I'm like you, Kalon. I like to just grab on the technology as soon as it comes out. In fact, I'm one of the guys who even download the beta.
Yeah,
it's not even ready yet. And I still want to download. Okay.
I thought about one.
Okay, what you got?
I still have the Wii. The Wii.
What?
Nintendo Wii.
Wow.
Yep, and I still play it.
I forgot about the Wii.
See?
Okay, that's pretty archaic. Okay. I think I'm gonna think about it here in a second. I can't even think of anything that's archaic that I hold on to.
No.
Yeah.
No, you're Mr. Technology.
Yes, you are. I don't see you holding on to anything. I really don't.
In fact, I have quite a few things that I would just like to get rid of that I have no interest in using again, but I don't feel confident enough to just throw it away. I don't know. It just feels like I'd be being wasteful because it still works.
Mm-hmm.
So let's turn this into a live sale. Start holding up.
I should do that one day. Just start holding up. I got all kind of stuff where I can sell, man. You know. Oh wow. Okay. All right. So we're wrapping up. We're getting towards the end of the hour here. There may be some things that I may have missed and didn't think of in terms of questions to ask you, because I'm sure a doctor, would have more questions. Like, what are the top 2 or 3 questions that you get asked about this type of service? Because I imagine a lot of them may be even holding on to some archaic form of technology in their RPM, and they're thinking like me. I got that on my dashboard, but I don't really do any of that. Mm-hmm. So what kind of questions are you getting to make them feel comfortable this is something they could take on?
I know one of the questions. I'm sorry, Kalon. One of the questions that we get is, does this involve more work for my clinical staff? That's a big one. And so we're just here to tell you that your clinical staff doesn't have to take on any additional work. All of this work is being done by us, but we would notify the clinical staff if something happened outside of the normal, something happened at home, we would keep the clinical staff notified. So that's huge because, like I said, doctors' offices are already taxed to the brim, and they do not want any additional work. So we're here to let you know that we would handle that responsibility. And as experienced nurses, we would be able to tell you if it's something you need to know right away, or if it's something that we need that we can tell you the next day. So no additional work. So that's huge.
Yeah, I can imagine they would ask that one. That's a good one. What about you, Kalon?
I think the main one is the bills getting paid. Mm-hmm. How is it billed through Medicare? Do you guys generate your own billing report and then send something over to us? Do we have to keep track of it? And how is the information flowing from your platform to our platform? Mm-hmm. And the answer to both of those questions is a positive one. One, we generate our own billing report. So by the time we give it to you, we've already had our biller look over it, make sure everything is what it's supposed to be, and then we submit it to them so that they can bill Medicare. And then number 2, is we always make sure that there is some kind of interface between your EMR system and our platform. And so it might be a drive that we have to hook up, but we have software techs that can work with a variety of EMR systems. And so those are the two main questions that we get. How do our systems interact with each other, and who's in charge of the billing, right?
Those are good. Those are excellent questions. Awesome. Okay, so since you did that, I have another question for you.
Okay.
All right, let's see what I got. So we can get you going. Okay, so imagine you had to have an operation where you're going to have your mouth kind of wired shut for, let's say, the next month, but you're going to be able to still function, but you're just not going to be able to eat and chew on food. So what's the final meal that you would choose before having this procedure done?
Oh, man.
Guys in the comments, tell me what you guys think. You're really watching live on the replay. I want to know what you guys think. Go ahead, go for it, Kalon. Kalon's ready.
Final meal. I'm going to Cajun Fuse, and I'm getting a big bag of crawfish, shrimp, and crab legs, French fries, and a couple of beers.
That sounds really good. What kind of beer?
I do Modelo Especial or Dos Equis or cold beer, whatever's coldest.
Well, okay, you just reminded me of the most interesting man. He says, "Stay." What does he say? Stay something.
Stay thirsty, my friend.
Oh yeah, they stay thirsty, my friends. I love that.
Yeah, my husband loves him. I forgot his name. Was it Dos Equis guy?
Yeah, Dos Equis. Yeah.
The most interesting man in the world.
There you go. Yeah. Is that what you call Lenny, Amy?
No, I got in public behind the scenes. Yes.
Okay, so Kalon, now you mentioned a lot of Cajun Creole food here. Now, do you have some Cajun Creole in you?
I do. My family is from small town near Shreveport, Keyshaw, Louisiana.
Oh wow, I didn't know that. I've been knowing you all this time. I didn't know you had that kind of background.
Yep.
And now that you say, is your dad from there? Because he kind of looks like he looked like he want to be one of my kin folks. The way
yes. I remember when I first met you, I was like, yeah, he looks like. Because what part of Louisiana are your family from?
Opelousas area, Washington, Louisiana, and then my of course he moved. My grandpa moved to Lake Charles, but he's from Washington, Louisiana, just near Opelousas.
Oh, okay.
Yeah.
Okay.
Yeah, wow. So that's cool. I didn't know that. Okay, I love Creole food too. I mean, that's my Cajun Creole food. That's my background. So you were hitting me when you said that crawfish, because crawfish etouffee is one of my favorite dishes.
Yeah, I think you got a tear coming out your eye, Rollins.
I was trying to get a little emotional. Yeah.
Well, I got to tell you, Tamara makes the best crawfish etouffee.
What? Are you serious?
With garlic bread.
Wow.
Over a bed of rice.
Wow. I learned how to.
I've gone a lot of places and I just don't like it, but man, hers was so good.
Mm-hmm.
I learned how to make it out of necessity because whenever I left to go out on my own, I said, "Mom, before I leave, I need you to teach me how to make gumbo, and how to make crawfish etouffee, and spaghetti." So I learned those three. So I knew wherever I went, because it's not, there's a lot of places that have spaghetti, but not too many places have good crawfish etouffee or gumbo. And so I learned how to make both of them. Now, since I got married, I can't say I've really done it that often because I got a great. I know.
You telling on yourself.
Hey, look, I got a great guy. She's a great cook. So I don't. This is the way I think about it, guys. If my wife is better at it than me, why not just let her?
Hey,
take care of it, right? She's better at it. She enjoys it. Now, if for some reason I have the edge and I have the desire over her, then I would gladly cook. But that's the way I justify it. Does that sound pretty good?
Is Jody listening? Can she put something in the chat? I need to hear from Jody.
It's almost convincing. Yeah, pretty good.
Yeah, she does all because she can cook not just Jamaican food, but also other, cuisines like Italian and things like that. So yeah, I enjoy it all. And of course I still love my Creole food, but yeah. This conversation is taking an interesting turn.
Yeah, it's probably just. Is this about a food show?
Everything gets back to food eventually.
I know, because people, especially when they tune in late, like, wait a second, I thought it was supposed to be talking about clinical staff. Jody says, "Get to cooking, Rollis."
Thank you.
All right, Jody. Oh, Jody.
Okay, so as we wrap this thing up, give me, your top advice of what you would suggest for whether they're going to use your service or not. If they're going to venture into this, what are some things they need to be mentally prepared to do these practices? And then I want you to also tell us what's the best way to engage with you guys. If it's going to be through LinkedIn, your website, what they need to do. So we'll go with you first, Kalon, and then Ammie. How about that?
Okay. My number one advice would be read up on the program, right? Read up on these programs that Medicare is offering, and then educate your patients on it, that it is available to them. Once you see all the things that Medicare is willing to do, because we just mentioned a few programs, but there's a number of programs that Medicare is putting into preventative health care. And so I would say read up on CCM for sure, RPM, and PCM. All of those are great programs to get your patients started on. And the best way to contact us is through LinkedIn. You can also visit our website at iChronicCare.com and request a demo for our program, and we can show you how we provide services and everything like that. But those would be my two main things. Just educate yourselves on the programs that Medicare is offering.
Excellent. Yeah. Thank you. How about you, Ammie?
Most definitely. You want to get that information about the program directly from Medicare. One of the things that I found that when we started this program, everybody's got advice on how you should do things and how you should go about things. It wasn't necessarily wrong, but it's like you need to go to the source who's actually reimbursing this. So go to Medicare's site, and they have information on every program, whether it be CCM, RPM, BH. I mean, they have tons of different programs, but understand where that's coming from and go to the CMS website and find out specifically about a program. And then if all else fails, you can always reach out to us. As Kalon mentioned, you can reach out to us on LinkedIn, and we'll be able to fill in those questions that you might have that Medicare doesn't answer. So, and there is no such thing as a dumb question, because we asked a lot of dumb questions in the beginning, but we do understand it now. So we encourage you, if you need to know something, we're free. We're here to answer any questions you have.
Yeah, no, and you guys handled my question very skillfully when I asked you about the RPM.
Cereal?
The RPM on my dashboard. Because that's when I hear RPM, that's the first thing I hear. I think of is my dashboard. But you guys kindly answered me on that remote patient monitoring. I actually learned that first from Lenny. Lenny helped me out. I talked to him about the CCM and the RPM. And there's one more.
PCM.
There's PCM.
Yeah, there are a lot more than that, but that's just what we're focusing on right now. So
okay, but all of them have the M, which is the monitoring. That's a key part.
Management.
Management. Okay.
And what's the other one, Ammie?
Principal care management.
They all have the management one.
Oh, management. Okay, management. Okay. So the RPM, does that remote patient
monitoring?
Oh,
monitoring?
No, it doesn't. You're right.
Okay. All right. So one of them is monitoring, the other one's management. Got it. Okay.
Yeah.
I got it. Yeah. Well, guys, look, it's been a joy. I get a chance to enjoy hanging around you guys all the time, but my audience, this is their first time. So I'm going to speak on behalf of the audience that we all really enjoyed this time with you. Thank you for being on the show. Appreciate what you're doing for healthcare and helping others get well and stay well and be well. So appreciate that. And so without further ado, we'll say bye to our crew here. And Joanne, if you'll hit the end button when we're good to go, we're going to say bye now. Bye, everyone.
Bye-bye. Thank you for having us.
Thank you for having us, Rollis.
Thank you for being on. Appreciate y'all.
All right.
Okay, so don't leave just yet, just in case.